Okay. Thank you all for joining us for this first session of the 2021 ISPD Virtual Education Series. My name is Mahesh Cholani, and I'm moderating today's webinar, which is focused on Spina Bifida. First, we will hear from Dr. Androkop, followed by Dr. Tim Van Meegen. Before we get started, I have a few announcements to share. If you need technical assistance, please use the chat function for support. Throughout the presentation, you can submit your questions for the presenters at the Q&A function. We will address these questions at the end of the session. You can use the thumbs up button to vote for the questions you like most, which will push them higher up in the question list. So first, I'd like to introduce our first speaker, Dr. Androkop. Androkop qualified at the universities of Oxford and London with training in development biology and clinical medicine, and a postdoctoral fellowship at Stanford University in the States. He's professor of developmental neurobiology at UCL Institute of Child Health, ICH, and honorary consultant at the Great Ormond Street Hospital, Gosh. Previously, he was director of ICH and non-exec director of Gosh from 2003 to 2012. His research focuses on genetics, development, and prevention of birth defects, in particular neurotube defects. Today, he will share with us new insights in the embryology, genetics, and prevention of spina bifida. Dr. Andrew, please.
Thank you very much, Mahesh, for that kind introduction. I'm most grateful to be invited to give this talk. And as Mahesh says, I'm going to speak about the development, genetics, and prevention of spina bifida. My aim then is to consider this abnormality in the embryo, failure of neurotube closure, and how we get from there to open spina bifida myelomeningocele. Right, so as I say, I'm going to talk about embryonic events, and I'm going to try and get us through to open spina bifida. So here are the events that happen in the human embryo during neurotube closure. And of course, this is the fundamental process that's going wrong, giving rise to most, but not all, neurotube defects. And so we have an initial closure event here, which we call closure 1, which happens actually at the junction between the brain and the spine at the base of the hindbrain. And then we have a series of zippering processes going up into the brain and going down the spine. As a further initiation site happens right at the very front of the brain, and zippering goes back from there. And so we have a neuropore, an opening which gradually closes in the brain, and a neuropore which closes in the low spine. And so we can then put on to this simple diagram the main defects. So craniorechiscesis, where you have anencephaly and open spina bifida, results from closure 1 failure. Anencephaly can result from failure of the neuropore here to close, or abnormality of one of these zippering events. And open spina bifida myelomeningocele will result from a failure of the posterior neuropore to close. And a fourth defect, which I'm not going to talk about in detail, but I'd be very happy to discuss in questions, is the whole issue of closed abnormalities. The neurosurgeons call this closed spinal dysraphism. And generally, we think of these abnormalities as being a result of secondary neurulation, which happens here in the tail bud of the embryo. So in my lab, we're looking at the events of closure. Here is closure 1 in a mouse embryo, looking from the dorsal surface, roughly halfway along the body, but in fact, at the base of the hindbrain. And then zippering going up into the brain, down the spine. And here just 5 somites, or 10 hours later, the embryo has closed quite a large part of its body axis, but the brain is still open and the low spine is still open. And so we're interested in the causes of the abnormalities of this process, the mechanisms in the embryo, and the processes of primary prevention and how we can improve that. So first of all, I'm going to deal with each of these, but first of all, here's something about the causation. So risk factors for human NTDs, as you all know, this is a multifactorial set of conditions in which genetic factors and non-genetic factors interact. Probably most cases in reality have both of those influences happening at the same time. In terms of environmental factors, there's a small number that are well recognized, valproic acid, the anticonvulsant, fumonisin, which is a fungal toxin that's been strongly causally associated with neurotube defects. And then maternal factors such as types 1 and 2 diabetes and alterations in folate status are known. Many other factors are known in animal studies, but very few of those have been shown to be actually operative in humans. Then looking at the genetic side of things, the epidemiological studies say that around 70% or more of the risk of neurotube defects is genetic. And so a lot of work has been done these days, culminating in whole genome sequencing to try to identify the factors in patients that are associated. And MTHFR was the original genetic variant that was associated. It's a relatively weak variant. It's confined to certain populations. And there is actually no role of MTHFR in animal neurotube defects, interestingly. GLDC, glycine decarboxylase, is a mitochondrial folate enzyme, and that has a much stronger association with both mouse and human neurotube defects. There are some other folate metabolic enzyme genes as well. And then the second big group are the planar cell polarity signaling pathway genes, entirely coming from animal research. So SELSA1, VANGL1 and 2, and a number of others have been associated with human neurotube defects and also can cause the defects in animals. However, I would say that the great majority of neurotube defects are sporadic, of unknown causation, and generally not syndromic, although there are a proportion, of course, that are syndromic, but the great majority are of unknown causation. So we cannot explain precisely what the factors are in this diagram that give rise to any one neurotube defect in most cases. So we have a complex, highly variable causation in these abnormalities. Now, what I thought I would do would be just to tell you about a couple of new concepts, or at least new concepts for me, in NTD causation, which will perhaps just give you an idea about a few of the other factors that might be considered in the future, although we're early on in our understanding of these. So I'm going to talk about mosaicism in the neurotube, and I'm going to talk about exon activation in females. So mosaicism, of course, is well known as a factor in many conditions, particularly in malignancy, where we can have mosaicism in a tissue and founder effects leading to clonal expansion of tumors and so forth. But it hasn't really been considered until the last year or two in terms of neurotube defects. So here is a mouse embryo. We're looking down on the dorsal surface of the posterior neuropore, so the spinal region as it closes. Here it is. This structure here. This is the zippering point at the asterisk, which is moving backwards. And what we've done here is use the Cre-LOX-P technology to inactivate the gene VANGL2, which is the planar cell polarity gene I mentioned, only in the green cells. So you can see the embryo is mosaic, and it has a number of green cells in the neural plate, therefore lacking VANGL2, but many pink cells which are not lacking it. And what was very surprising in this study was that we could inactivate as few as 16% of these cells in the neural plate and yet still get spina bifida. And so clearly this then opens up a whole new possibility, which is that many, and I would say possibly most, neurotube defects may turn out to be mosaic, in fact. So this can contribute to the sporadic nature of the neurotube defects. Often there is no obvious inheritance, and that could be part of this reason. So we published this paper earlier this year, and the main focus of our study was to try to understand how as few as 16% of these cells can actually make the neurotube stay open. And so what we found was that there is a cell non-autonomous mechanism happening here, which amplifies the disruption. So VANGL2, when it's lost in these green cells, influences neighboring cells to also behave abnormally, so that ultimately the whole neural plate fails to close. Now, this may be a specific feature of planar cell polarity genes like VANGL2. We're now about to make some other mosaics which contain mutations in other genes that are not planar cell polarity, and so we'll find out whether it's a more general phenomenon. In terms of humans, this is clearly important as well, because this group in 2020 showed that somatic mutations in PCP genes are also present in human fetuses with neurotube defects. So we feel this is an important new area. Secondly, I want to talk about sex differences, because we've been puzzling for many, many decades over the fact that anencephaly here is commonest in females with a 2-to-1 or even a 3-to-1 sex ratio, whereas spina bifida has roughly an equal sex ratio. And this has been reported in many, many epidemiological studies. In many strains of mice, the same thing happens. So we produce embryos that have only spina bifida and they show an equal sex ratio. We produce embryos that have the exencephaly, the forerunner of anencephaly that you see here, and they have a preponderance of females. So why is this happening? Juroloff and Harris back in 2012 proposed an exon activation model, and it's never been tested until now. And so we're just testing this at the moment. So XY males, of course, do not undergo exon activation. They have a single X. They want that to be active. XX females undergo an activation of one of their X chromosomes chosen randomly within the embryonic structure itself. So the key factor in this hypothesis are the methyl groups. So exon activation requires large quantities of methyl groups to be used to methylate the X chromosome and inactivate most of the genes on it. And so the female embryo, because exon activation occurs before neurulation, the female embryo is going to have relatively fewer methyl groups than the male. The male has got plenty because it's not using them for exon activation. The female is using them. So therefore, events in the embryo which are required for closure, such as regulation of key genes, methylation of key proteins, those could all be adversely affected by the relative lack of methylation. Okay, so that's what I wanted to say about causation. Now let's go on and talk about mechanisms a little bit. Now, in the case of human neurotube defect mechanisms, we're in a situation where there is a very large literature that's based mostly on what I call backward extrapolation. So many of the neurosurgical papers and some of the genetics papers, such as this very highly cited paper by Margot Van Allen and colleagues, and back in 1993, take the appearance of neurotube defects in children and in fetuses after abortion, and they go backwards to predict the developmental events. And so what I want to think about here is the origin of encephalocele. So this paper suggested that encephalocele was specifically a defect of closure 4. This closure 4 event here. And so this paper really built on earlier rodent studies to suggest that there are all these different closure points in the human embryo. The problem with this is that when we actually look carefully, and I've already told you this, there are really only a small number of closure points in the human embryo, closure 1, as we saw, and closure 3, but these two don't exist in the human embryo. In fact, this closure 4 doesn't exist in any mammalian embryo that we know about. So this can't be right. And this is a diagram from Ronan O'Reilly's paper using the Carnegie collection, which shows that there is a single closure 1 event, a closure 3 event, and zippering between them, as I said at the beginning. So occipital encephalocele, which is shown here and which we would expect to arise here somewhere, cannot be as a result of a failed closure event as such. So how does it actually develop? So here's frontoethmoidal encephalocele, here's occipital encephalocele, and these are often classified, usually classified as neurotube defects. But they are quite different from open defects. They're strongly syndromic. For example, Meckel syndrome has occipital encephalocele, and that's well known now to be a ciliopathy, an abnormality of genes specifically functioning in the cilium, in the primary cilium. There's uncertain prevention of encephalocele by folic acid. There are as many studies that show no effect as those that do show an effect. And up till recently, there have been very few convincing mouse models, which has hampered our experimental understanding. So does encephalocele really share pathogenesis with open neurotube defects like anencephaly? So we had an opportunity to look at this recently because we made a mouse that lacked the small GTPase RAC1 using this Cree line. And basically this removes it from the surface ectoderm layer of the embryo. And in the litters of these mice, we found, quite remarkably, we had 3 different phenotypes, all of which occurred at roughly the same prevalence within the litters. We had normal developing embryos, we had those developing exencephaly, and we had those developing a different brain defect, which looks remarkably like Occipital Encephalocele. So these all have the same genetics, but they are doing different things in terms of their cranial development. And when we look at brain closure, that's normal in the normal embryos. It fails in the exencephalics at 9 days, but it's normal in the embryos that have this defect. They close their brain normally. Subsequently, these embryos herniate their brain out through the surface of the embryo, and of course that doesn't happen in the other 2. The brain is already outside in the exencephalic because it didn't close, and the normal is normal. And so you can see what this looks like in cross-section. Here's a normal closed brain covered by skin and subcutaneous tissue, and the skeletal elements are just developing. And here is the encephalocele. The closed brain herniates through the surface layer, and the surface layer in this case is mutant, so this probably explains why it's herniating, and this occurs before skeletal development. So the brain closes, it herniates, and then the skeleton, the skull develops with a big hole in it for the opening, around the herniation. So encephalocele then is not a primary closure defect, at least in this mouse model, and I suspect in most other systems, including humans, it's a post-neurulation defect. What about open spina bifida? Well, we'd like to study the human embryo, of course, and these are all human embryos that have come from the HDBR, the Human Developmental Biology Resource, which I co-direct in the UK. So we can get embryos that have an open posterior neuropore to study. We can get slightly older embryos that have an incipient spina bifida. Here, this region is open. And we can do, to some extent, some descriptive studies of the posterior neuropore as it's closing. But what we can't do is to do longitudinal studies, of course, because these embryos are no longer viable. But the posterior neuropore in the human embryo is remarkably similar to that in the mouse. These are beautiful images of my colleague Gabriel Galea. And what he can then do, of course, is to look as the development progresses. We can see the neuropore getting much, much smaller, eventually completely closing. And then the secondary neurulation process beginning caudal to it and developing further down the body axis. So one thing we've been doing recently is to try to understand how the zippering process occurs, how the wave of closure passes down the body. And of course, this is the process that fails, giving rise to spina bifida. This is a continuous process in the embryo, and it moves at a considerable rate, 0.2 millimeters per hour, over about a 40-hour period in mouse development. And so what we've been doing is live imaging of cultured embryos so that we can see individual cells as they border the open neuropore, as they enter the zippering point, when they become, you can see they become elongated, especially their medial ends, this light blue cell here, and then they eventually exit over the top of the closed neural tube. And what we found was that this process is exquisitely sensitive to the protein integrin beta-1. So if we knock out integrin beta-1, again using a conditional Cree-LOX-P system, we can block this zippering process, and we get spina bifida in a high percentage of cases. So integrin is a receptor for extracellular matrix proteins, and so what we're currently doing is looking at the other side of the equation. We're looking at the matrix proteins that bind to integrin, and fibronectin in particular is implicated. And we've recently knocked out fibronectin in the same way, and we get the same defect. Okay, so finally then, just to talk about prevention for a few moments and what we know about that so far. So primary prevention, if you think about it worldwide, really consists of two approaches. There's voluntary supplementation, as occurs in the whole of Europe, UK included. Women either take supplements or take an enriched diet, for example, or they don't, but it's entirely voluntary. Or the situations such as you have in the United States, where there's mandatory fortification of bread flour. And that's now been going for more than 20 years in the United States. So the whole of the Americas have adopted fortification, as has Australia and South Africa and some countries in the Middle East. But the whole of Europe has decided not to do that. Fortification delivers about 100 micrograms of folic acid per day, which is about a quarter of the recommended daily allowance. So it's not a large amount, but it's been shown to increase the folate status of everyone in the population. So the effect of this, if we compare the prevalence of neural tube defects in the United States and in the UK between two periods in the 1990s and the following decade, and fortification began between these two time points, is that there has been a dramatic, significant reduction in the prevalence of neural tube defects overall, both spina bifida and anencephaly in the United States. And the same is true in Canada and Southern American countries and so on. At the same time, there's been relatively little change in the prevalence in the UK. And so whereas the USA and the UK started in the 90s with not too dissimilar prevalences, now the USA shows roughly a 7 per 10,000 prevalence, whereas the UK is still over 10, is about 12 per 10,000. So the USA prevalence has fallen, UK shows little decline. Clearly then, on a population level, mandatory fortification works in the sense that most countries show a reduction. Voluntary supplementation does not work on a population level, although clearly it does on an individual level. But the other point I want you to notice is that more than 5 per 10,000 NTDs persist. So the USA is now fully fortified for 20 years, and yet still shows us a 7 per 10,000 prevalence. So what can we do in future about these cases that appear not to respond to folic acid? So we've been working on this for a long time. Again, we began with a mouse, the curly tail, grainy headlight 3 mouse. And this mouse has spina bifida, which does not respond to folic acid, but does respond to this 6-carbon ring inositol. We've used either myo-inositol, that's the common form, and also D-chiro, which is an isomeric form. Both will prevent the spina bifida in these mice. And so this led us to begin a clinical trial, which we did a few years ago now, in which we were trying to essentially replicate the original folic acid trial. So that trial used, recruited women who'd had a previously affected pregnancy, and so they were at high risk. They probably had about a 1 in 25 recurrence risk. And we did the same thing. We recruited a number of women in that situation, and then asked them if they would be randomized to either receive 5 milligrams of folic acid, which all of them did, and a gram of inositol or a placebo. In fact, quite a lot of the women declined randomization because they wanted to take inositol, which was a surprise when we did this study. We followed up both types of pregnancy, and most cases had normal birth outcomes, of course, because the recurrence risk is about 1 in 25. But we had 3 recurrences in this study, all anencephaly, but they only came from women who were in the folic acid only groups. So we would hypothesize then that folic acid for these women, most of these women had taken folic acid in their first pregnancy. They are essentially folic acid resistant, and yet it appears, or it is possible, that by adding inositol, we can give them further protection. In fact, we now have approximately 100 pregnancies that we've documented of women at high risk who've taken inositol and folic acid and have had normal outcomes. So what we're trying to do now is to set up a large-scale study, a large-scale phase 3 trial of inositol with folic acid. We're doing this in collaboration with colleagues at Peking University in Beijing. And what we're hoping to do is to recruit a large number of women, because we need a very large number of pregnancies to make this sufficiently powered, from provinces around Beijing. And this group here have a lot of experience of doing clinical trials in pregnancy during this time in this region. The important thing is that in China, certainly in these provinces, there's pretty much 100% ascertainment of abnormalities during pregnancy. And so we can identify immediately all the women, and there are very large numbers of them, who have had neurotube defect pregnancies, and invite them to join the study. So if this trial should have a positive outcome, then obviously we would want to encourage folic acid and inositol usage. And of course, we need to explore the possibility of a combined supplement for the future. So just to conclude then, we've seen that neurotube defects are multifactorial in causation, and I've shown you a little bit about genetic mosaicism and exon activation. There are multiple mechanisms involved in the embryo: closure of the neural tube, post-closure herniation in the case of encephalocele, and I didn't talk about it much, but secondary neurulation defects as well. And primary prevention is partly effective with folic acid, but only partially. And so we're wondering whether inositol may be a useful adjunct to folic acid for the future. And thanks to my colleagues, both my senior colleagues here in the Neurotube group and in the HDBR, all of our other colleagues here, and our funding bodies. Thank you very much, and sorry about the trouble at the beginning.
Thank you, Andrew. Thanks very much. So we will next hear from Dr. Tim Van Meegen. But before I introduce him, I just want to remind everyone that you can put your questions for the presenters in the Q&A function, and you can use the thumbs up button to vote for the questions you like most. Okay, so Tim is a maternal fetal medicine specialist at Mount Sinai Hospital, Toronto, and associate professor at the University of Toronto in Canada. He completed his training in obstetrics and gynecology and a PhD in biomedical sciences at the Catholic University of Leuven in Belgium. And then he went on to do his fellowship in maternal fetal medicine at the University of Toronto. Dr. Van Meegen's research and clinical practice focuses on prenatal diagnosis and the treatment of fetal anomalies, in particular central nervous system disorders. He has authored more than 100 papers, peer-reviewed papers, and 15 book chapters in the field of fetal diagnosis and therapy. He's an associate editor for the Journal of Prenatal Diagnosis and an editorial member for Ultrasound in Obstetrics and Gynecology. Tim will share with us his talk on Spina Bifida, what we should be telling the parents. Tim, over to you.
Thank you, Mahesh, for introducing me. And this talk is going to be a little bit more clinically oriented than what we just heard from Dr. Kopp, but basically works off a lot of experimental studies that were done in the past. I do receive some research funding, all in the field of prevention of spina bifida or early imaging. None of it is going into my personal pocket, unfortunately. So this will not affect what I'm telling you today. And the layout of this talk will basically follow a little bit what we described in a recent article that we published in Prenatal Diagnosis in the What We Tell the Parents series. And for those of you who know Prenatal Diagnosis, who know the journal, and who follow this series, this is basically a series of articles that really go back to the basics of some fetal conditions and describe a little bit how to counsel parents from a very practical perspective. So for those of you who don't know this, please look out for it. There's articles on spina bifida, but also on abdominal wall defects and a whole bunch of other conditions. And so what I'm going to talk a little bit about is really looking at how do we diagnose spina bifida, what kind of workup is needed once you've diagnosed the condition, and then what are the outcomes and what treatments can we offer before or after birth. Now, in most places, spina bifida has really become a second trimester diagnosis and an ultrasound diagnosis. So we've really moved away from the alpha fetoprotein screening, which had a high false positive rate of screening. And I think that most societies in the developed world really rely on ultrasound. And the ultrasound findings for spina bifida are quite striking and typically don't look at the lower back. And so what we're looking for is really the lemon shape of the head and the banana shape of the cerebellum, so the Chiari-2 malformation that we're seeing. For those of you who don't know what these fruits look like, this is the lemon here with the bulging of the temporal bones, and this here is the Chiari with the banana-shaped cerebellum. And we do know that if we look at these signs, that we can diagnose spina bifida much more easily, because detecting the lesion at the level of the back is not always easy. And if you look at countries with a well implemented screening program, then we know that probably 80 to 100% of cases of spina bifida are diagnosed in the second trimester. Now, in many cases, when we see patients for their second trimester ultrasound and when we diagnose spina bifida, the big question that comes up is, well, why was this not diagnosed at my first ultrasound? And we've read some articles on the internet saying that spina bifida can now be diagnosed in the first trimester. And that's true. Spina bifida can be diagnosed in the first trimester. And what you see here is the picture of a normal fetus in the first trimester, where we can see the normal brainstem, where we can see the fourth ventricle and then the posterior fossa. And then here on the right side, the picture of a fetus with spina bifida, where we can see that posterior herniation already of the hindbrain in the first trimester, where we see the Chiari malformation. And this was published by Rabi Shawi and collaborators in 2009 already. And this is obviously something that is being read by parents and has been even further reinforced by a publication 2 years ago by the group from UCL around Fred Ushakov, who described the crash shine, basically on axial findings showing that in babies with spina bifida that you've got that posterior herniation of the hindbrain, that you get the posterior movement of the aqueduct and where you lose the posterior fossa. So basically exactly the same images as in the second trimester. And so parents will always say, well, look, this has been described. Why did my doctors not find that? And if you look at systematic reviews, or if you look at data from the Fetal Medicine Foundation in London, then indeed they describe that probably 70 to 80% of cases of spina bifida should already be diagnosed in the first trimester. But that is not what is happening in real life. And to get a nice real life picture of diagnosis of spina bifida, I think that the registries do a better job than series from isolated centers, even though they're sometimes really large series. And one of the good European registries looking at timing of diagnosis for spina bifida is the Eurocat Registry. And so what you can see here in this graph is a list of different centers here on the left, and then the kind of timing of when the spina bifida was diagnosed in the bars that you can see here. And so you can see that in excellent centers, for example, like in Switzerland, in the French-speaking part of Switzerland, that spina bifida is diagnosed prenatally in 100% of cases, but that the diagnosis was made in the second trimester of the pregnancy, so the black bar, in probably about 70% of cases, and in the first trimester only in 30%. And that's in the very best performing region, because if you look at all other regions, then you can see that the diagnosis of spina bifida is not uniformly made during pregnancy, and that still in some countries up to 20-30% of cases of spina bifida are not diagnosed prenatally. So that's the blank spaces here. And that if you look overall, that only a minority of centers have a really decent first trimester diagnosis program. And that in most centers, say, for example, Paris here, that prenatal diagnosis in the first trimester only happens in about 20% of cases at the very best. So I think that in summary, for prenatal diagnosis, spina bifida unfortunately remains a first trimester diagnosis. But that hopefully over time we're going to get better at diagnosing it in the first trimester. The second question that parents ask is, okay, so now my fetus has been diagnosed with spina bifida. Where do I go from here? And what we would always recommend is that the next step would be a referral to an expert center for further diagnostic workup. And that diagnostic workup consists of two parts. The first part really is ruling out other abnormalities. And at our center, we would advise further genetic testing for these fetuses. And the routine test that we offer is an amniocentesis with microarray. I do know that in some centers, whole exome sequencing is an option. That's unfortunately not a possibility with us because it's not funded by our healthcare system. So further genetic testing, because we do know that about 10% of fetuses with spina bifida will have underlying genetic conditions, including the common trisomies, but also more rare microdeletions. The other test that we would recommend is a detailed ultrasound and MRI, first to confirm the diagnosis, but second also to rule out other associated abnormalities. And we do know that besides the fetuses with genetic abnormalities, another 10% will have underlying structural abnormalities. Once we are talking about isolated spina bifida, we would really recommend an accurate estimation of the level of the lesion. And that is something that I see does not often happen in smaller centers that are not very familiar with spina bifida, and is really a critical part of the diagnosis because it allows you to counsel parents properly. And when you ask me, or when parents ask us how should the level be assessed, well, then I think that we have really decent data now suggesting that the best way to look at the level of spina bifida during pregnancy is with 3D ultrasound. And what you can see here in the graph is how accurate different imaging methods are in predicting a lesion level compared to postnatal findings. And so you can see that only about 35% of 2D ultrasounds will have a level that is the same level as what is shown postnatally. 3D ultrasound will be in the range of 70%, and MRI will be in the range of 40%. If we're then talking being one level off, so say calling the lesion an L5 lesion when postnatally it's an L4 lesion, then we can see that 2D ultrasound does a little bit better. About 70% of cases will be within one level of the true postnatal level. 3D ultrasound reaches about 95%, and MRI reaches about 75%. And then when we're looking at within two levels, then most techniques achieve about a 95% accuracy. But so if you compare these bars, I think that you're most likely accurate with 3D ultrasound. And this is just a picture of a 3D ultrasound. And what I always like to use in my clinical practice is a combination of the rendered image, what you can see here in the bottom, with the 2D image in the B plane that you can see here in the top. And then you can really scroll through your B-plane images until the first open level, and then count on your rendered image which level that is in relation to your ribs. Good. So now we've looked at prenatal diagnosis, we've done the workup, and we've ruled out other associated genetic abnormalities or structural abnormalities, and we know a little bit about the level. How do we truly counsel these patients? Then what do we tell them in terms of prognosis? And to do so, we really take them a little bit back to the pathophysiology of spina bifida. And so what we do see in spina bifida is that typically the lower end of the neural tube is not covered and is open. And we see that the neural elements are exposed at the level of the skin, and so get damaged gradually in the third trimester of pregnancy by two factors. One factor is the amniotic fluid, which is toxic for the nerve elements there and results in gradual damage of the nerve elements. The second factor is the fetus jumping around in the uterus and bumping the lower spine into and the nerve elements into the uterine wall, and therefore causing microtrauma of these nerves, which results in a gradual loss of nerve function at this lower level. The second thing that happens in these fetuses is that the cerebrospinal fluid, which is basically in combination or in continuity, between the lower spine and the brain, leaks out at the level of the defect here. And that leakage results in basically a suction on the back part of the brain and results in a Chiari-2 malformation and a hindbrain herniation into the top of the spine. And that kind of shift of brain anatomy results in an abnormal flow of cerebrospinal fluid in the lateral ventricles and results in gradual buildup of hydrocephalus. And so these are the factors that will come into account when we're counseling about postnatal outcomes. Because the most common problem in these fetuses is hydrocephalus. And even though the hydrocephalus is not so much of a problem before birth because the skull bones have not fused, after birth, the skull will start fusing and the hydrocephalus will start pressing on the brain and will start pressing on the hindbrain and cause the typical postnatal signs of intracranial increased pressure, intracranial hypertension. And we do know that looking at a different series of fetuses that were managed expectantly during pregnancy, that about 70 to 90% of fetuses with open spina bifida will require an intervention for hydrocephalus after birth. Typically, that intervention is ventriculoperitoneal shunting, where the neurosurgeons insert a small catheter in the lateral ventricles that drains the excess fluid through a subcutaneous tunneled system into the abdominal cavity. But nowadays, more and more, neurosurgeons resort to endoscopic third ventriculostomy and choroid plexus cauterization, which as such also allows the cerebrospinal fluid to drain from the ventricles to the extracerebral spaces. And in fetuses or in children that have hydrocephalus, certainly if it's a little bit later in life and who have an optimal anatomic configuration, this treatment can prevent the need for a ventriculoperitoneal shunt. And reducing the shunt rate is really a critical thing in these kids, because even though we know that shunts typically work well, we do know that a significant proportion of shunts will get blocked or will dysfunction or will be complicated by infections, and that certainly affects quality of life and causes neurodevelopmental problems later on in life. The incidence of hydrocephalus is, given its very high occurrence, not so much level dependent, although we know that in the lower level lesions and especially in the sacral lesions, hydrocephalus can be a little bit less than in the higher lesions. A thing that is extremely level dependent, though, is motor function. As I said before, we do know that the nerves at the level of the lower part of the cord get traumatized and get damaged over the course of the pregnancy, and that will result in motor and sensory dysfunction at the level below the lesion. And so we can see that that impacts on mobility after birth. And so what you can see here in this graph is from a really large series of kids treated expectantly before birth, and comparing their ambulatory function with the level of the lesion. And so you can see that in most kids with a sacral lesion, those are community ambulators, and those kids will be able to get around with minimal walking aids or maybe ankle orthotics. Same thing for low lumbar lesions, but when the lesion starts getting into the mid lumbar region, and certainly if we go high lumbar and thoracic, then you can see that more and more kids will need to rely on wheelchairs or walking aids. So that's why looking at level of the lesion is really important. Prenatally, we will also talk about urinary dysfunction, bladder dysfunction, and urinary incontinence, as well as bowel dysfunction, with mainly constipation and sexual dysfunction later on in life. And unfortunately, these findings are close to universal in kids with spina bifida, irrespective again of the level of the lesion. In our setting, we typically prefer to counsel patients in a multidisciplinary team. So that means that MFMs, neurosurgeons, and developmental pediatricians who are in charge of the postnatal follow-up program here in our area will counsel the patients so that we make sure that these patients get a wholesome counseling addressing really all of the factors that I've discussed before. What do we speak about from an obstetric perspective and from a pregnancy management perspective? Well, we do counsel our patients that in fetuses with spina bifida, the risk of preterm birth is slightly higher than in fetuses without spina bifida. And the exact reason for that is not entirely clear, but there may be some underlying placental dysfunction, and growth restriction might also be a little bit more common in fetuses with spina bifida. We speak about mode of delivery, and overall, there is no clear evidence that a cesarean section is better for postnatal outcomes than a vaginal delivery. We do make an exception here for fetuses with really large lesions, saccular lesions, where we may prefer a cesarean section over vaginal delivery to prevent damage of the myelomeningocele sac. We do speak about reduction of latex exposure because for some reason, kids with spina bifida have a really high risk of becoming sensitized to latex. And that is probably related to the fact that the blood-brain barrier is breached at the level of the lower spine. And so all interventions on these kids from delivery onwards are latex-free procedures. And then we, or the neurosurgeons more particularly, speak about postnatal surgical closure of the lesion, typically within 24 hours. Since the publications of the MOMS trial results, we also speak about fetal therapy, and we mainly speak about open fetal surgery. Open fetal surgery is still, in our eyes, the state-of-the-art prenatal treatment for open fetal spina bifida, and is a major maternal procedure where we perform a laparotomy through which we expose the uterus, expose the fetal lower spine, float the fetus up to the incision, and then try to mimic the postnatal procedure that is done. So the neural placode is detached from the skin, is dropped back into the spinal canal, and then the muscular elements and the skin are closed over the neural placode, eventually with the integration of a dural patch. We typically still counsel parents based on the MOMS trial results because that was the really level 1 evidence to show that fetal surgery for spina bifida improves outcomes for these fetuses compared to postnatal management. A bunch of follow-up studies have been done from a range of centers, both in the US and across the world, with varying expertise in terms of fetal therapy. But the brief summary of all these studies is that they show exactly the same as what was demonstrated in the MOMS trial. And that means that overall, the risk of the kid needing a ventriculoperitoneal shunt or passing away because of the spina bifida decreased from close to 100% to about 70%. And the actual shunt rate decreased by half, going from 80% to 40%. We typically also see an improvement in hindbrain herniation during the pregnancy already, and about 30% will have a recovery of the Chiari malformation during pregnancy. And in the long run, this results in better motor function. And so you can see that when studied at the age of 30 months, so 2 years and a half of age, that the MOMS trial showed that the cohort that was operated prenatally had about double the number of kids walking independently compared to the group that was managed conservatively during the pregnancy. Now, it's important that in our counseling that we stress that motor function at the age of 30 months is maybe not such an important factor to aim for, because many of these kids will still lose part of their ability to walk independently later on in life. And so I think that certainly in our counseling, we mainly stress the benefits in terms of shunt reduction, more so than the reduction in or the improvement in motor function. We do speak a little bit about bladder function, although the evidence there is not as clear as for motor function and shunt reduction, but there may be some slight improvements in bladder function, but the truth is still out there, and I think that there is multiple studies looking into that further. We clearly stress that the benefits to the fetus come at a risk for mom, and these are the risks that were demonstrated in the MOMS trial, so showing a risk of pulmonary edema after the surgery. Moms have also probably a longer hospitalization during pregnancy because of the surgery, and then there is the the pain from the surgery and the recovery of the surgery, as well as restrictions to physical activity basically for the remainder of the pregnancy. I think that the numbers, if you look at more recent series, have gone down compared to the MOMS trial, and the maternal risks have certainly decreased with increasing surgical experience. The main risk of fetal surgery is still the risk of preterm delivery, which is about 34, 35 weeks now compared to 37, 39 weeks in fetuses who do not undergo fetal surgery. We briefly touch on the option of fetoscopic repairs. I think that at this point, this is still very experimental. Different techniques have been proposed by different centers, and long-term outcomes are still lacking, but it's certainly very promising for the future. And for those of you who want to have a nice overview of what is available at this point, there is a really nice, or there are two really nice systematic reviews by different groups that have been published in the last couple of years. And lastly, we speak a little bit about future pregnancies, and Dr. Kopp already spoke about recurrence risk, and overall, the recurrence risk of spina bifida has been quoted as being somewhere between 2 to 5%. I think that in recent years, and certainly in North America, the recurrence risk is more in the range of 2% than 5%. Starting high-dose folic acid at least a month prior to conception has been shown to decrease the risk of spina bifida in future pregnancies and decreases the risk of neurotube defects by probably 70 to 90%. I think there is less data available on vitamin B12 and inositol, but certainly high anxiety patients in our population have been recommended to take those other two medications. And of importance, I think, is that we really stress this to the maximum. Because we do know that only about 35 to 85% of women with a previous child with spina bifida will ultimately take high-dose folic acid in future pregnancies. So there is still a big knowledge translation gap going on there. And then lastly, in women who have undergone fetal surgery, we speak about the risk of the scars in future pregnancy and the risk of uterine rupture, which is probably in the range of about 10%. So in summary, to round all of this up, and you've got the more extensive description of what we counsel about in the article. But in summary, we tell our patients that spina bifida is still a second trimester diagnosis at current. There is certainly promises for the first trimester. Once spina bifida has been diagnosed, we recommend referral to an expert center for further workup and individualized counseling. Fetal therapy is an option for selected cases, and in our eyes, open fetal surgery is still the gold standard, but fetoscopy is probably what we're working towards, and prevention is key in future pregnancies, and we really stress that a lot. Thank you very much. That was a little bit in a nutshell what we speak about with parents with spina bifida.
Thank you, Tim. Thank you very much. Can I ask Andrew to switch on his camera? Yeah, perfect. So we have some questions being asked, and I think we have time enough to take a few of these questions. Perhaps the first question we can take for Andy is, what could be the theoretical causes for folic acid resistance in mothers if they do not have a diagnosable genetic defect in the folic acid pathway?
Yes, thank you. That's an interesting question. I don't think I can fully answer it. The problem is we don't actually know what folic acid does in the embryo at the moment. So therefore, it's very hard to talk about the theoretical causes of resistance to it. We know of situations in mice where folic acid is effective, and we know situations where it's not. There are different causations, there are different genes, for example. In addition, it's important to bear in mind that a mutation in a folate metabolic pathway doesn't mean you will be folic acid sensitive. So the gene that I talked about, the mitochondrial folate metabolic gene, GLDC, glycine decarboxylase, the mice that lack that develop spina bifida and neurotube defects, and they do not respond to folic acid. So it depends on the precise role of folic acid in the embryo, which we have a partial understanding of at the moment.
Thank you. There's a question here for Tim. Does the fetus feel pain during the third trimester upon exposure to the nerves?
Yeah, so we do know that from probably somewhere around 22 weeks onwards, fetuses can theoretically feel pain. And that is why, for example, during fetal surgery, fetuses are given pain medications to treat this. I don't think that we have any evidence to suggest that open spina bifida in itself, when it's untreated, causes pain to the fetus, and it's a little bit similar to brain surgeries. For example, we do know that the central nervous system in itself does not feel pain, and so some kinds of brain surgeries are done without any anesthesia. So we think that is a bit the same mechanism going on there, but we don't have strong data to support that.
Thanks, Tim. Andy, which inositol supplements can a woman take at this time?
Well, there are no inositol supplements that are actually marketed for this purpose. I recommend, when women ask me, that if they decide to take this, they should take 500 milligrams per day from several weeks before conception, exactly the same as for folic acid. It's quite easy to buy single inositol tablets online, and they are nutritional supplements essentially, but there are 500 milligram tablets available online.
Tim, what are the risks of open fetal surgery? I presume to the fetus and to the mother, I guess, yeah.
Yes, I think it's for moms, it's still a major surgery. So it's still a laparotomy during surgery, conducted under general anesthesia. So it's all the risks of surgery in pregnancy, and that's why we select an extremely healthy maternal cohort prior to proceeding with open fetal surgery. So that means that moms with severe comorbidities are by definition excluded from fetal therapy. In the MOMS trial, you saw that there was an increased risk of bleeding and needing a blood transfusion. There was an increased risk of pulmonary edema. Certainly in our cohort, we've seen one patient develop a deep venous thrombosis and a pulmonary embolism after the surgery, and that's why we're very aggressive on anticoagulation in these patients. And then there is the typical surgery-related risks of infection and wound complications that we watch for. For the fetus, the main risk is the risk of preterm birth. The risk of in utero death is probably only 1 to 2%, and is not much higher than the risk of postnatal death that is seen more commonly in pregnancies that are managed expectantly. And then obviously the risk of preterm birth that I briefly touched on. These fetuses are typically born 5 weeks earlier than fetuses who don't undergo fetal surgery.
Thank you. In the interest of time, I think we can take one last question for each speaker. Andy, for you is, could the reduced effect of folic acid supplementation in the UK be because of delayed start of supplementation?
Yes, I mean, I'm sure that's correct. I think it's a very precarious situation when you rely on women to be sufficiently accurate in their planning of pregnancies that they will take folic acid in advance of conception. It will happen sometimes, but mostly it won't happen. And it will tend not to happen in the women who are at the highest risk anyway, socioeconomically. So this is why fortification is so effective, because it removes that requirement for women to plan a pregnancy specifically and take folic acid while they're planning it. Yes, absolutely, I agree.
Thank you. And last question for Tim. First trimester diagnosis, would that allow surgical intervention earlier?
I think first trimester diagnosis would allow a couple of things. So first, if you diagnose the condition earlier, you can start sooner with further investigations. And so, for example, you can start doing your CVS or your genetic testing earlier in the pregnancy, which certainly saves some time. If you only diagnose the spina bifida at 20 weeks or 22 weeks, by the time the patient gets referred to a tertiary center, they'll be 23 weeks. By the time you get your microarray results back, they'll be 25 weeks. So yes, if you diagnose it in the first trimester, you'll be able to start intervening or working up and intervening probably a little bit earlier. Now we're still going to be limited, certainly with the current therapeutical approaches, by the fetal size and the strength of the fetal skin. So we do know that interventions before 20 weeks of pregnancy are kind of not feasible because the fetal skin is so paper thin that any kind of sutures will tear through. So at this point, usually open fetal surgery is done somewhere between 22, 23 and 26 weeks. But certainly I think that looking towards the future, if we're looking to more minimally invasive treatments, if we're looking to stem cell treatments, these kind of things, then yes, an early diagnosis would make an early treatment possible.
Thank you. Thanks, Tim. I'm afraid that's all the time we have for today, and I'm sure there are more questions we can, ask Tim and Andy directly. I'm sure they'll be happy to answer. But this concludes our first session of the ISPD virtual education series. I want to thank everyone here for joining us today and giving a special thanks to our speakers, Dr. Andrew Kopp and Dr. Tim Van Meegen. The presentation is recorded and will be available at the ISPD website within a week. Now, certificates of attendance will be sent out by ISPD within 10 business days. We'll be having another presentation of the virtual education series next month on Wednesday, the 5th of May, 2021. So please visit the website for more information. I want to thank you all, wherever you in the world you are. Have a good day, have a good evening, and stay well. Thank you.